Um, so I believe when I do the playback on this recording, I could add notes. And if that's possible, then I'll definitely do that in order to make this a little better for you. So, any specific questions that I might have glazed over too quickly then? Bueller. Okay. All right. Well, don't be afraid to stop me for any reason. Not all gonna be upset. In fact, I want you to stop me when you need it. But let's. Yes.
Will we be able to rewatch this later, and how?
Yeah, I'm either gonna post it. I'm crossing my fingers because I've never done this. I'm recording to my hard drive, and then it converts it to a format that can be posted. So either do Vimeo, although that's been giving me problems lately. So it might be a YouTube as well. A nice thing about YouTube is you could put it on 1.5 speed. I might sound like a squirrel, but you can go through it a little faster and pause it whenever you need to as well. And like I said, I'm going to try to hopefully add notes or annotate more when I review this. I'm not 100% sure I have that ability, but that's what I'm hoping for. Hey, actually, I have a question for you guys on this image right now. So obviously there's, I have a structure in the middle of my screen here, but as I go off to the side here, can you see like maybe half of a picture over on the side here?
Yes, we see half a picture.
You see, okay. All right, I was a little concerned about that because I have my extra screen is like one of those really wide ones. Okay. All right. Well, then let's get moving again. Live and learn, and we'll, if anyone needs any kind of questions answered, we can go back. We could all go back, or I can go back individually. But we're going to start talking about some pathology of the abdominal wall and pathology of the diaphragm. Now, when it comes to abdominal walls and diaphragms, there's really well, I guess about 3 things. There's abscesses, there's cancers, and then there's hematomas, basically bad bruising, and there's a few other things. But what we have image here is it looks to me to be an abscess. So an abscess is a infection. It's an inflammatory process. There's bacteria. There's there could be pus involved in a abscess. Necrosis. So you have tissue that has been
Sorry.
That's over.
What page are you on, sir?
Oh. Let me unmute you, Priscilla.
22.
Yeah, as far as page 20.
Those images don't appear in the book, correct?
No, I pulled most of these images off the internet.
Okay.
Yeah, basically, oh no, wait, hernias, groin hernias. Oh, we're not into hernias yet. No, sorry. Hematomas. 24, really, if you're going to follow along in the book there. No. Okay. So an abscess. Why do I feel like I'm missing good grief, Kurt. CESS. Yeah, okay, that's right. Abscess. Inflammatory response caused by bacteria that's not supposed to be there. So, if you have post-surgery, you could have an abscess. Any kind of a GI tract, if there's a hole in the GI tract, that can create an abscess as well. And there's actually, technically, there's a sterile abscess as well. A sterile abscess is one without bacteria, but basically creates the same type of structure. But in this case, we have a regular abscess with bacteria, with probably layers of pus in here, and perhaps some dead material as well, which would be necrosis as well. So we have pus, necrosis. So we can call this abscess, since this does look like there is pus in there, we can call it pyogenic, or let's see, chronic suppurative, chronic suppurative inflammation. So just inflammation. So this is one. This is a typical abscess appearance. Abscesses are mostly fluid filled, and so they fill the shape of whatever space they're occupying, kind of like water would fill the space that it was occupying. And this abscess is right below the skin level. Now, one of the things we want to do also when we're looking at an abscess is to determine where it is. So, and I don't mean obviously, where, right upper quadrant, left upper quadrant, where it is. I mean how deep it is. Because there's a big difference in treatment of an abscess that is very close to the skin, like this one appears to be. And I have a hard time. Oh, we get a little bit of a indication of where this is. This is left lower quadrant, transverse image, assuming someone updated that when they were using this. What I'm trying to figure out here is why I see obviously a skin level here and subcutaneous level, and I guess this person may not have much muscle mass at all, because it kind of seems like if this is layers of muscle, remember there should be 3 layers of muscle there. If it's off to the side, there's the external, internal obliques, and the transverse abdominis muscles. So this seems awfully thin. But if that's so, then what I'm not seeing is a clear delineation of the peritoneum. That is a fascia plane. But it does appear to be subperitoneal. This is going underneath the peritoneum and actually almost pushing up a little bit. And yeah, almost looks like it's so inflamed in here that it might actually be crossing over the peritoneum, which I'm not sure how that would happen other than perhaps this is a surgery site or a site of injury with resultant bacterial invasion. But in any case, doctors want to know, is the abscess or any mass, when we're talking about the abdominal cavity, is it, anterior, or is it retro? Peritoneal, I'm sorry, it's really hard to draw or write it with that. Is it retroperitoneal? Is it below the peritoneum, or is it above the peritoneum? All right. I chose this picture because it has some nice, we've got a few things going on here. So we have a liver. Now, if you guys know a little bit about what a liver looks like, it normally does not have a shape like that. This is the right lobe of the liver. It is up high. The diaphragm, not well seen on this patient, but the diaphragm is basically coming around. Oh, that's right. You can't see me do that. The diaphragm's coming around this way. I'm not sure what this is, but I am sure what this is. That does appear to be an abscess. The C might stand for clot, but this is definitely has an abscess type appearance to it. And it's actually one of the places where we can find it. This is a potential space for bacteria to gather and not be well attacked by the body. There's not a lot of blood flow in this space. This space is basically between the diaphragm over here, what appears to be the diaphragm like this, and the liver itself down here. So that is a typical spot to find an abscess in the abdomen. Abscesses, I also failed to mention, they could sometimes be filled with air. Of course, if you have bacteria growing in here, they will produce gases. As we move along, this image, I do believe, is in your book. And I think it gives a different explanation for what this is. I think the book says this is a umbilical abscess, which it very well could be. And here we have the rectus abdominis muscle on either side here, and you can see where this basically is a defect in our body. It's a closed defect, hopefully, but a defect just the same. And your book said this is an abscess, and it certainly does look like an abscess. It's heterogeneous. But as I found the same image on the internet with being used by an article, well, supposedly found by the people who wrote the article, this is umbilical endometriosis. Now, endometriosis is something we're going to talk about next semester, but that's basically endometrium that's supposed to be inside of the uterus, and it grows and then sheds every month. But sometimes those cells get, they travel a little bit, and they can travel to the inside the abdomen, and they can form endometriomas, or these little endometrioma type plaques. And supposedly this one is really just inside, just under the skin of the belly button. So endometriosis in a 33-year-old woman with painful swelling to the umbilicus during menses and cyclical bleeding. Transabdominal ultrasound image obtained with high-resolution linear probe shows a hypoechoic nodule with irregular margins and tiny cystic areas that occupy the umbilical scar. So, Anyway, so I guess the jury is out on whether or not this is endometriosis or abscess, but it's actually a good example, and one of the reasons I used it, that we don't always know whether or not it's which is which. In this case, if this history is true, then it lends to I forget my dog barking. It lends to the endometriosis. However, if her white blood cell count was high, white blood cells, of course, are used to attack an abscess. If her white blood cell count was high, then that would lead us down the road of saying, no, perhaps this is a abscess. There's another image that I really liked here. And this one could look like an abscess. It's a little solid looking as far as abscesses go, but it looks like there might be fluid there and maybe some fluid here. So perhaps this is an abscess that's packed filled with pus and necrotic material in there. But instead, what it actually is an abdominal wall hematoma. And we could see our 3 layers of muscle. We come over, and by the way, this is a good practice to do when you have something unusual, something you're not used to looking at. Look at both sides of the body for comparison. Here we have the external obliques, the internal obliques, the transverse abdominis. And well, this last line, certainly right here, that would be the peritoneum. And this would be like you could almost tell these two apart. Here's the fascia here. That's a horrible arrow. Here's the fascia for the transverse abdominis. And then this line is most likely the peritoneum itself. And so anything down here is within the peritoneum. And in most cases, that's going to be, intestines. So we don't see a whole lot here. You can see where this person took a pretty good hit. It looks like some kind of trauma. And well, a hematoma, hema for blood, toma is Spanish to give someone. I don't think that has anything to do with it. But a hematoma is basically a bleed. It's a bleed under the skin. It's a bleed in the muscle. It's a bleed somewhere else. But it is a bleed. This person was hit hard enough to internally bleed, essentially. However, this blood is all anterior to the muscles. They've been deviated downward. They look a little swollen even. And you can see the fascia. You can almost see that one going across, eventually creating an aponeurosis. But this hematoma is large enough that it's actually causing a deviation or a shift in the normal anatomy. So hematomas are another thing we can see. Let's see, I just had to look at my notes real quickly here. It could be within the muscle, within the rectus sheath, you can find a hematoma. Hematomas that are captured within a sheath can be especially painful because they have nowhere to grow. They're within that fibrous sheath, and the blood is pouring into the hematoma, and it has nowhere to go, and that causes more pain and potentially damage. There is a situation of working out too hard. Here we go. Well, okay, this isn't exactly what I was thinking it was, but it's this is a hematoma as well. An unusual fluid space within the muscle. We have one muscle group surrounded by fascia, and then another muscle group down here surrounded by fascia. But this fluid here, as you can see from this side of the image, over here, is blood and the plantaris tendon. So not exactly the abdomen. This is more of a calf muscle. We have gastrocnemius is the main muscle of the calf. That's the muscle you see, and then deep to that is the soleus calf muscle. And actually, I was just mentioning blood getting into fascia like this, or getting into a compartment. I know this might be a little bit off topic since this is a gastrocnemius muscle, but if this blood were to go into this compartment, it has no really way to get out, and so that becomes very painful, and it could actually cause so much high pressure in the muscle that the muscle actually can die or become a little bit necrotic. So that's called compartment syndrome. But like I said, that is a little bit outside of what we're talking about today. And so what I was when I was first thinking when I saw this image over here that this was a different process. It looks like this person is actually they've destroyed their plantaris tendon. But what I was thinking it could be like if let's say we had fluid in the middle here, or sometimes towards the end of the muscle, towards the attachment zone. I've seen this on a few young men who work out too hard trying to get big. And in that case, when the muscle breaks down from overwork, that was called rhabdomyolysis, and that's a breakdown of muscle. One way of doing that is working out too hard. Wow, that's not what I meant. All right, look at okay. Pretty much all I have for you right now, what time is it? It's only 2:30. All right, well, this is day one. This is practice anyway. So we'll see what we're going to do. I might just assign some reading and such. Or if you guys like me to go back on anything, I'm more than happy to. These two images, there's actually absolutely nothing wrong with this patient. I just figured I realized after looking at all of this that there's a lot of drawings, but not a whole lot of ultrasound. And students do like to see ultrasound images because that's what we're here for. But beautiful, beautiful picture of the. Beautiful. Let's pick a different color anyway. Oh, shoot, my somehow my layer's on the wrong side. Okay, well, actually, can I use a different mouse text? If you see that's probably better. Draw. Okay. Yeah, this will allow me to draw on. I have each image here is actually a different layer, and my drawing layer is supposed to be on top, and somehow these got on top, but I could draw it with this one. Anyway, beautiful rectus abdominis muscle. Rectus abdominis coming across. These guys are really close together. This person has a very small or very narrow linea alba there. Peritoneal layer down here. So this down in here is a peritoneal cavity. This is some air right along here. You guys can probably see that better. That's much, I'll use that in the future. There's air down here. That's in some intestine. And of course, we're not seeing well beyond that, so it's not even worth looking. Skin level, skin. Basically, here's our subcutaneous fascia layer. Subcutaneous fascia layer does have some fat in it as well. This person has very little fat, and one of the things I mentioned earlier is how I was confused with a psoas muscle that I thought was a tumor. It was so large, so well developed that I thought it was a tumor. Well, when you look at muscle in transverse, you're looking at the fibers straight down the barrel of the fibers. You turn on that muscle, and this is not the same person apparently, because there's a little bit more subcutaneous tissue there. But as we turn on the muscle, suddenly all those fibers are stretched out, and so that's how you could tell that, oh my God, there's a tumor, and you turn on it. Oh no, that's a muscle there. Oh dear. X. Oh dear. Oh, I erased this quickly though. Nice. Okay. And there's just one last picture for you guys, just because it was pretty. Remember when we started, I talked about you start off your exam in either a sagittal or transverse in the epigastrium. This is a beautiful picture of the liver from the epigastrium. It is oblique. It's transverse, but a little bit oblique, so that it is looking a little more towards the patient's right shoulder, and it's looking up, and probably the patient's taking a nice deep breath as well in order for us to see. But once again, this is all liver here. Diaphragm comes around like that. This is really lung space here. Over here, we're actually seeing part of the heart. That's hard to see, but the sonographer is not concentrating on this. They're concentrating on the liver. This is a beautiful picture. We're going to learn this really soon in our vascular class. We have two separate kinds of vessels, two separate kinds of veins in the liver. We have hepatics. Oh God, that's pathetic. Hepatic veins and portal veins. But once again, I am getting into stuff that we don't need to do right now. Any questions? Got too many controls here. Huh. Well, anyhow, Any questions on today's lecture? I've heard your complaints that you didn't quite know where I was all the time, and I'll try to fix that. But anything, or are we good so far?
I think we're good.
You're exhausted? Okay, let me end recording before you say something bad about me. No, I'm just kidding.